working with organizations like ARC. He is recognized nationally as a leader in the field, particularly for his work for the ARC Integration Academy to develop a lexicon for behavioral health integration, and we are absolutely thrilled to have him with us today as a resource for you all. So I think I can pass it over to you now, CJ, if you're with us on the line.
Okay, I'm here. Should I go?
Sure.
Okay. Well, great. Oh, thanks for that kind introduction. You know, as you said, I've been in this field for quite a while and helping to set up. I spent many years as a practicing clinician, seeing patients in medical settings that were complex and training psychologists to work in primary care back here in Minnesota at Health Partners. So what I thought I would do here for just a few minutes, after reading the excellent report and the other materials, is just to try to put your work in the context of a larger field, as I understand it to be. So sort of like how the report lives in this larger context and some of the things that might be useful to be aware of as you talk about the report and the evidence recommendations within it. And then we'll just take questions and see where we go. So there are just a few points. One of them is the idea of usual care. And in a technology assessment paradigm, typically, you know, you have a new intervention or a device or a medication or something, and you compare it to usual care, where the presumption is that usual care is reasonable, and is this actually an improvement on it? In this field, there's a little different thing about usual care, because it's very hard to find anybody who will consider usual care to be acceptable at all. That is to say, the problems of access, that people don't get to mental health care, they don't take referrals out, the access is challenging, care is fragmented between mental health and medical. Most of the prescriptions are written by you know, primary care doctors, and the list goes on, and I'm sure you're familiar with it, and a lot of that is in the report. So in a way, what the field is already, the horse is out of the barn already on, we got to do something to rectify the fragmentation. So it's the comparison for, I think for most people, isn't against usual care. The comparison is against what one kind of integrated behavioral health versus our other alternatives for doing something. But not doing something isn't really on the table. And that helps explain something else that may come up in the meeting, which is that the huge uptake on this idea, even without the kind of evidence basis that you've been researching so nicely in here. For example, the fact that the multiple states are picking it up. I was just not long ago helping to edit some legislation for the state of Oregon ACO Act and about integrated behavioral health and big care systems and the SIM grants, and it's like everybody's doing this, so why? I think it's because everybody sees a need to do something other than usual care. So when you have the comparison to usual care and the technology assessment thing, it's a little different in this field, just to be aware of that. And then the other thing is something that you've addressed too, which is that behavioral health integration is not itself an intervention. It's like a heading, of which inside there are a lot of interventions. For example, your report distinguishes the collaborative care models, which is a family of interventions based on a common platform developed heavily at the University of Washington with the PCP, the care manager, consulting psychiatrist, registry, monitoring, and various processes all in a nicely tied together process. And so that's one kind that you point out in there. And then there's others, which you have as other sort of non-collaborative care methods. And it's interesting about those, just to be aware of those, is that those other models, the so-called behavioral health, BHC or behavioral health consultant models, often have a very wide targets. Whereas the collaborative care model start out as care of depression, and you use a PHQ-9 and depression scores and so on. You monitor those disease outcomes. That's often what you encounter in care systems like Cherokee and others, is you've got very wide targets, like, and it's for all comers. So if it's a mental health condition like anxiety, depression, great. If it's a person that's stuck in diabetes and doesn't even know they're depressed and maybe doesn't have a real major depression diagnosis, but they can't get moving, or they have headaches and stomach aches or symptoms without medical explanation, or they're really stuck with health behavior change, or even that the doctors are bogged down with certain cases and need help themselves. A lot of times in the behavioral health consultant models, the doctors are considered customers too. Like, how do you help them with manage their practice, be comfortable, get better at things, stay in the profession longer? I mean, these kinds of things. So it's this broad target of many of these programs, which is sort of clinically meaningful, but the problem is it's hard to research. So the research is behind the game on that, because there's so many things that are outcomes. So which would you choose and how would you measure them? And for example, in your report, it talks about additional benefits or value in the value assessment framework. That has a variety of actual targets for integration, and then in the section says there's no quantitative measures for it. And this becomes a research challenge that involves mixed methods, qualitative and quantitative, and we're behind the field on that, although there are many things out there. So in a way, part of what you encounter in an evidence search is that the evidence basis is not nearly as mature for these sort of broad-based, clinically oriented things that have all these different targets in them. So that's one piece of context for it. The other one I would say is that in the field, your scope has been the integrated care for behavioral health conditions. In the field, there's also this whole wider scope I mentioned about somatic patients and chronic illnesses and all that kind of stuff. So when people say behavioral health integration, they mean more than conditions usually. Your report nicely gives a broad definition and then narrows your scope. The other thing is that, like most of the evidence is in RCT kind of clinical trials, and one of the things there is that a lot of the research that's been going on isn't necessarily clinical trials or RCTs, and like the Diamond project for depression, which is a collaborative care model process, used different kind of designs so that it was a natural experiments, and clinics came on every 6 months, and they were their own baseline, and so it was a different kind of design, research design that are out there. And part of the research challenge is how do you study natural experiments and these things unfolding in real time when you can't really set up a trial, or at least you aren't able to. And the other thing that's important, I think, is that the results, one of the things that's been coming out is that the quality of implementation of a given model, sometimes it's not just the model that's efficacious or not, but how well did they implement it? And a practice, there's some variation on that. So a practice that's really good at implementing can get better results than one using the same model, but they don't implement it well, or it only works on Tuesday and Wednesday when certain people are there, that kind of thing. So there's this interaction between the model and the implementation. And then the other thing I was going to mention was about leads me to the active ingredients. Like in your figure 6 is really good. It says we identified 36 models of integrated care that reported statistically significant improvements. And then there's a list of functional components, which I read not really as models, but as like active ingredients, like standardized care coordination plan, regular interaction with the patient and physician, formal patient education, and so forth. And sometimes there's a lot of hypothesis that no matter what model it is, if you implement those things well, you get results. And that's a research hypothesis to do. And then that leads me to my final point at this introduction, is the use of a perspective on the SAMHSA standard framework that you use in the report, which is a wonderfully accessible way to get the hang of integrated behavioral health with 6 levels and 3 categories and 2 in each, and adds up to 6 levels. It makes it very accessible and easy to get the idea of what's going on. Has great value there, and it's been around the field, so it's very recognizable. But the thing is, when it comes to this functional things, it's a little challenging because the framework has everything moving up the levels of integration together. So spatially gets closer, the collaboration gets closer, the systems get closer, as if they all move together. But in actual practice, they don't move together. So sometimes you can change the spatial thing, but the level of collaboration hasn't changed, or vice versa. And so if you're implementers getting down to the real functional things, that doesn't contain all the functional definitional stuff. And that's where some of the ARC work is much more granular, dense, harder to read, but it gets into some of the details that if you're an implementer, you want to say, so exactly what do you mean by regular follow-up? What are those 6 elements? And that kind of thing. So anyway, I'll just stop there and let you go from, see what else I can be helpful with.
Thanks.
Perfect.
Thanks, Dr. P. Go ahead, Esther, sorry.
Oh, no, I was just going to say thank you. That was wonderful.
That was great. Dr. Peek has had practice. He actually also gave clinical perspectives, or I should say clinical expert perspectives, policy expert perspectives to our California group. I would just want to encourage the members of CEPAC who are on the phone to think of this as an opportunity, again, for you to ask any kind of question that you feel like you need to ask to get your feet on the ground with this topic. It could be about clinical issues. It could be about implementation issues. We do, though, encourage you to look at the voting questions because often we forget about that until too late, and you might have some specific questions about them and how they relate to the evidence that it would be great to ask Dr. Peek about. So any questions from members of CEPAC about this report and what Dr. Peek has told us?
Hi, Steve. It's Mitchell.
Hi, Mitchell.
I started to correspond a little bit with SJ on this question, so maybe I'll kick it off the discussion with this, which is the collaborative care model. The voting questions were revised to separate out CCM versus the other techniques.
Right.
And I have to say that trying to read through the report to tease out the different pieces of evidence was difficult. So I don't know if the evidence presentation on Friday will address that, or if there are some easy charts that we can refer to, or how you suggest approaching that question.
Thanks. That's a great way to start us off. So yes, and I'll also just make kind of a high-level comment for your guys' benefit in terms of the perspective on this. There is a certain kind of competition, sometimes friendly, sometimes not so friendly, in the policy world around this topic between those who favor, if you will, the evidence supporting the CCM model and those who feel like other models have not had the benefit of time to be studied and maybe are more difficult to study, but that shouldn't be, in a sense, put into second place just because they don't have the same strength of evidence. That's something that you guys are going to be thinking about, and we did end up changing our voting questions based on this public feedback because we felt that ultimately it would be helpful for policymakers to have separate votes on the CCM model and other models. So that came after we had pretty much put together the report, though. But what we're going to do is that in the slides and in the the verbal presentations from Jeff Tice and Dan Ohlendorf, we will go a long ways towards helping separate the evidence on these two general approaches so that you can see them more distinctly. Jeff or Dan, do you want to add anything on that?
No, I agree. Thanks, Steve. This is Jeff Tice. I was just going to say essentially what Steve said. We received a lot of feedback after the report was out, and we changed both the voting questions and the evidence presentation to reflect those comments, in particular that almost all of the randomized trial evidence is based on the collaborative care model. And that will be reflected in the presentation on Friday, but it's not it's not clear in the current draft of the assessment. It will be in the final draft, but just acknowledging the appropriateness of your struggles because the voting questions did change after the assessment was frozen.
Yeah. And also, this is the last report for CEPAC on the old model, the old timeline of getting public comments. And going forward, as I think we may have discussed, but going forward, we're going to have an earlier round of public comment on the first draft before we even send it to CEPAC, so that we can get comments back in and make adjustments to the written material in the report before it gets sent out to you. So we'll have I think what will end up being a better process in terms of getting a report that you end up reading that is going to be a closer match to the voting questions. So that was a good first question, very important high-level question. Other questions for Dr. Peak?
Hey, Steve. This is Steve Kogut.
Hi, Steve. Go ahead.
Good afternoon. Thanks, Dr. Peak. It was a great opening for this. I'm looking at the budget impact analysis and some startup costs that are sort of non-trivial with pursuing this model, and wondering what's known about improving depression care and primary care, just in trying to get primary care maybe doing a better job with evidence-based treatment of depression as a first step. Wondering if you have any insight on, any work in that area.
Yes, I think there has been a lot of work, and I'll just refer to some of the work I was very close to in Minnesota, where in the Diamond Project, I don't know if, how many of you are familiar with that or heard of that, but what it really was is an intervention based in the collaborative care model. But it was implemented in 80-some practices across the state by agreement by all the health plans that we'll all pay a bundled care management fee for depression to cover the cost of care coordinators. So all the plans, including the Medicaid, and the only payer that wasn't in the picture was Medicare, agreed to do this, and then all the practices got trained, and they implemented a very concrete protocol that had, here are the elements you have to have fidelity to, and here is a column of all the things you're going to have to invent for yourself, the local tailoring, and all the choices you have to make locally. But in order to be in it, you got to be able to do all these 6 things. And so, and then that was launched, and people talked about it like in a collaborative, and the depression outcomes, the relapse and the response things got very good, and I mean, it was much better. Our own practices went from, I mean, they went way up. But here's my lesson, is that it's important to know what you're doing, have a vision for it, have leaders decide to do it, and then set it up correctly. Set it up so it really works, and not just, again, it's back to the quality of implementation. And when you do an intervention or a system that you understand, and it's led as if we're going to really do it correctly, then the responses were really quite good. Some of the papers aren't out, but some of the things I hear from those papers are that, in clinics that didn't get as good in outcomes, the implementation wasn't as good. So I think that's a big lesson. But we found it in our programs that many people found a relief. We know what we're doing with depression. We're not stumbling around. We're not all doing a different thing and giving different messages. And the costs were higher than the reimbursement of the care coordinators. But many people felt like we're doing enough better of a job, and it's cleaning up this messy part of our practice enough that, it's kind of worth it. They didn't really lose a lot of practices because the bundle payment didn't quite pay for the thing. So people stayed in it. Does that help?
Yeah, it does, and it helps me too to understand a little bit more about what we were speaking out before as far as teasing apart the chronic care model elements from behavioral health integration, and now I can maybe see a little bit more clearly how those two are sort of intertwined and they can happen at both levels, so it does make it very complicated.
Yes, it can, because you can have both the collaborative care model and the VHC model in the same setting, and that's how we did it in our residency training programs. We had people that were part of the medical care teams that were psychologists. We just figured out how to do it with everybody, including the psychiatrist. What's important, though, for the behavioral health consultant models that are out there, and it's not always true in the reports you read, is they have to carefully specify the process. What is the intervention? What are the supporting processes? What are the tools? What does it mean to monitor? Now, authors of the collaborative care stuff at the University of Washington, starting with Kate, are very careful about that. They were sort of natural researchers to begin with, so they were very careful about describing what they're doing. And not all the behavioral health things are as careful about that, but that's one of the things they need to become more careful so that you can actually do these studies.
Excellent. Thank you.
Good. Other questions from CEPAC members?
Hi, this is Lefteris.
Yes, hi. Nice to have you on the call.
My pleasure. I was wondering if there are any data available that CCM can help decrease the stigma associated with psychiatric illness, and if this provides better access for patients.
Well, that's a very good question, and it's I'm waiting again for the final papers, some of that are in press or they're trying to get out now that may address that empirically. Anecdotally, in the Diamond Project in Minnesota, it was quite popular among patients, partly because they could see that there was a method they could work on, and they loved to be in contact with their care coordinator, who was the person they were mostly working with, not their PCP. And they never saw the, usually didn't ever see the psychiatrist. Psychiatrist was in the background helping the care coordinator and the PCPs, but often didn't see the patient themselves. But the connection was with the care manager, who was like a coach, who would call up. And a lot of these people said, when they come to the meetings to give testimonials, they said, you know, it became something I could do, and this person really stuck to me and helped me be successful, and I really appreciate it. So in a way, it turned it in from, I have a big mental illness, what am I going to do, into this is a manageable problem that I can do something with. Now, that doesn't really answer your question in general, but it's the framework of turning it into a manageable thing that you can handle in the clinic, talking to somebody who's a care coordinator, and you're not just seeing a shrink, for example, which is a classic thing people worry about. That's not a very good answer, I realize.
Thank you very much.
Good. Thanks. Other questions? Well, I have one if you're thinking. I want to come back, I guess, to the point that we'll probably keep hitting over and over again during the meeting itself. But the focus on in a sense, the process elements of CCM versus other models, and and how we interpret a body of evidence. So there was actually a really excellent blog posting today in Health Affairs from a person who was commenting on the broader literature around care management in integrated healthcare systems. And he was saying, we spent all this time focusing on scaling up certain processes, like outreach, screening, whatever it might be, when what we really need to focus on are culture and principles, because there are organizations like Group Health, Health Partners, Geisinger, whatever, where they just seem to get or have the culture that makes something like BHI thrive, and other groups can try to paste on the same processes but just never get there. Yeah. So first, I'd love to know your perspective on that, Dr. Peek, and then also how you think it should lead CEPAC to look at the public literature on the quote-unquote effectiveness of these different models.
Well, that's interesting. I agree that in a way it goes back to what I was saying about integrated behavioral health isn't just an intervention or like in a technology assessment paradigm, kind of like a new drug or a new device where everything around it stays the same and you're adding something, but it isn't like a profound change in the whole setup. It's just a new thing you're doing. And practices that say, well, we're not really having to change. We're just adding a function. We're going to get a care coordinator. We're going to get an outreach. We're going to do this. But we are the same. If our mission is the same and the cultural thing hasn't changed, in my opinion, don't do as well as people that realize, things like this. Behavioral health and depression is actually part of our primary care practices. That is our job, isn't it? Our job is not to just send people out and give them an 800 number And we have to realize that most of our work is behavioral, and we need to get better at it, and we can't do it alone. But we still have PCPs, but we need partners. And then here's how we operate together. So then I will know, for example, one of the important things for a doctor is how to introduce a behavioral health consultant or a care coordinator so that the patient doesn't think they're just being offloaded. And you can rehearse doctors in how to introduce their colleagues, and then retrain psychologists to be able to feel the situation in a primary care clinic where the person might even say, I'm not depressed, I don't have a mental health problem, but that doesn't bother people. The clinicians can just pick up the thread. So there's a lot of functional things. It's like who you do, what the job is, who you do it with, and what counts as a good job. I think the places that do well really do articulate that well for their people. I know, having worked at Health Partners, we had done a lot of that for every time something big changed. Cherokee Health Systems, I know the people there, they are very big on the meaning of it and how it's different. And so it's not just a bolt-on, a new thing while we stay the same. And I think one of the things in reading the literature would be to look for studies that articulate the cultural dimension of the change. And what I wish they would do, in fact, this might be a tip if you're going to make suggestions to the research community in your final product, it would be to report much more about how these things were set up. Not only what were the processes of the interventions, but how did you prepare people to do this, and what was the meaning of this? Why did you do this? Why did you have to do it? And all that kind of thing. So that when you read a research report, you can tell if anything happened there or not.
Yeah.
That was the first part. I'm sorry. What was the second part?
No, well, I think you covered pretty well the general question
Okay.
that I was raising, which was, in a sense, how to interpret the existing literature given what you think driving success or lack of success of these different programs.
Yes, I think so. I wish that they would be more clear about the process that they use, so you know what the intervention was and how people work together. I mean, just not say here's the intervention and here's the results, but really look inside the whole thing so that you could look at the ones, and also how well implemented was it. You know, how well was it implemented? You know, was it only half the time, or what?
And I'll have one follow-on question for you, and then see if there are any other questions from CEPAC. So, in an emerging technology like this, even if it were a pill or a test, but certainly for delivery system innovation, sometimes people worry that what ends up published has a strong bias towards studies that show a positive effect.
Yeah.
That any system of care that tries this and this kind of doesn't work out, the energy it takes to write it up and to try to submit it for publication often isn't there. Yeah. Do you think that publication bias is something that people are aware of in the field right now, or that CEPAC should be aware of?
I think CEPAC should be aware that that's a theme in almost all research right now. And there's a number of papers that have really pointed at the disincentive to publish negative results for the kind of reasons that you that you cite. And so, yes, I think the collaborative care or the integrated behavioral health literature is not immune from that problem in the overall thing. People get promoted for their positive results, and that's what attracts, feature articles in journals. Replications aren't valued. You get something that showed a good effect, but then really somebody ought to try it again in a very similar but not exactly the same context. Can we do it again? But, grantors and careers and stuff aren't necessarily made by replications. They're made by these other things, and that's a general problem, and this field is not immune to that. This is why I think it would be good to have sort of like a position, a set of recommendations on how to tackle the gaps in the research on the various approaches to behavioral health integration, including being more careful about specifying the differences between them. What are the goals? Like I was said earlier, sometimes there's this hugely broad range of goals, and some programs are population focused, like kids with special needs or pregnant mothers, others are anybody, others are more geriatric focused, and then what are you actually doing, and with the behavioral health person, what do they do when they get in the office, other than you can't just say they spent 15 minutes. What actually is there, are they doing? Do you have processes in place is there a registry? Is there regular monitoring? What evidence do you have that if the treatment wasn't working, it was quickly adjusted? Or if the patient didn't accept the care plan, it was quickly adjusted? Or if there were side effects to it, it was quickly adjusted? You know, like all that stuff, if you could somehow make resolutions that people would have to report that and then look at it, I think it would help. And then I think reward that if it's perfectly honorable to try to repeat something somebody did in one system. Try it again. And if you have bad results, learn from them and publish those. And then we should encourage journals and others to do that. You know, this reminds me, a lot of this stuff is sort of in the realm of quality improvement now. And ARC and others are coming out with how do you get generalizable knowledge from quality improvement projects over a large number of practices. And so how can we take QI that people do, which is more like evaluation and not research, how do we get generalizable knowledge that we can use across this? And so that's where that's pretty far from RCTs. But it's going to be, I think, part of our future in understanding what works or not.
All right. Super. Thank you. Does anybody else have any comments or questions that they'd like to ask Dr. Peek?
I have a question. This is Tony.
Sure. Hi, Tony. Go ahead.
Behavioral health is such a problem for primary care, and behavioral health integration certainly has face value. So can you speak to why the benefit that shows up in the evidence is so consistently small? Is there something else going on, or are we just not good at measuring what the benefit really is?
Well, I think it's partly there's several things there. One is that most of the measures, like in the report, are about clinical outcomes. And there are other outcomes that matter to people doing this. Did I get my patient in? Actually, instead of only a few got in, they almost all get in. That's big, but that doesn't really show up in an outcome study like this, because it's the ones that get studied are the ones that made it into it. But the fact that most people don't ever get in, if you don't have integrated behavioral health, they mostly don't go to mental health centers. So how do you? So there's outcomes that matter to people. Here's one that's interesting. When I was doing this at Health Partners, one of the things that was very important to people was access. Can we get them help when we know they're never going to see anybody or going to get help, and they're just going to cycle around in the primary care system and come back, and I don't know what else to do, and I'm not going to kick them out, but I've run out of gas, and they won't go anywhere else? That's a big problem. And if your behavioral health integration will loosen that up, and people get seen, and they get some motion, and some of it's in the clinic, or maybe that therapist helps them realize they do have a mental health agenda and gets them hooked up with a family therapist, or they go to the domestic violence program instead of just coming in with a headache every month. Those are outcomes that really matter. So sometimes people make management decisions about funding or doing a program by what they see its effect on the people in it and the patterns of utilization and that kind of thing. So that's different stakeholders have different things they count as evidence, whereas the report is pretty much clinical outcomes on mental health disease measures. That's a small part of the total outcome picture that people are attending to.
Thanks, Steve. It seems like we're going to need some additional guidance at the meeting as to what we should be considering in this.
Well, there's nothing at all wrong with the evidence you are considering. I think the only thing is just to realize that it isn't everything that people care about right now. That's all. And a lot of it is in that those sections that you talked about as health system value and additional benefits, that where there aren't really measures, but you already got a placeholder for it. But actually, a lot of what people care about that keeps them going in this lands in those two categories,
Thanks.
especially the access part.
Right, which got back to Dr. Milanakis' question about stigma and other things. I think there's, go ahead.
The other thing is that when patients can go to their primary doctor, they sometimes get mental health care and they don't even know that's happening because they'll be in there for their diabetes and they're stuck and they're depressed and they can't get going, or they have headaches and stomach aches, and they don't never have to admit mental health. They don't have to go to a thing that says mental health clinic and sign up and have a special chart and everything. And so in some ways we make it easy for them to think of it as just part of my health care. And then when you train doctors to say, you know, the good news is you're not dying of anything here, but you know, you have a serious issue here with the stress in your life and the way this is playing out physically, and I have a really great partner I work with all the time. I'll still be your doctor, but you know, I really need that person's help with you. Right. Can I introduce them to you right now for just a second, and then you can come back, and it'll be the same parking lot and the same front end, and you know, I mean, that really is destigmatizing in effect for many people.
So let me ask you to follow up. This doesn't really directly relate to that, but one concern, I guess, that I've actually heard from some patient advocates in looking at the evidence on collaborative care models is that basically what they do is they take people and put them on antidepressants. That integrating behavioral health into primary care, since primary care doctors are never going to be adequately trained to give any kind of therapy, that unless you're using the behavioral health consultant model, and there is a mental health clinician there, that basically what you're doing is putting people on antidepressants. What do you think the evidence suggests about, I guess, the balance between antidepressants and counseling that occurs in CCM?
You know, that's a wonderful question. I actually don't have the answer to that from reading it, but that would be one of the things to look closely for if it were reported, is how many of these people was the treatment pharmacologic, period? How many of them was it pharmacologic and some other things? How many was it not pharmacologic? And who did it? So that you had a sense of the mix of treatment plans. And the beauty of the CCM thing is they have this pretty much rigorous process for you having a registry and having a panel and looking at monitoring and changing things. But it'd be really nice to know the answer to, is it just a way to get better medicines or not? And I don't know the answer, but I'm sure that could be found out. You could probably find out from the AIMS Center in Washington that has done a lot of research, that Jürgen Unitzer's outfit at the University of Washington. It probably could tell you that, or has data that you could find out about.
Okay.
But I've heard the same concern that is it just medicine, and I don't think it is, but I don't know.
Okay. Well, we'll try to look into that and bring it to the council.
Yeah, I mean, I can comment a little bit. This is Jeff. I mean, certainly some of the analyses of looking at the sum total of the collaborative care model suggest there is added benefit to having some sort of non-pharmacologic therapy available. The original trial that really started this was the Partners in Care trial, where they had a QI, cognitive behavioral therapy arm and a QI medication arm and a usual care arm, and they ended up lumping the two QI arms together because they had similar outcomes. And certainly part of the impact model, the Jürgen Unitzer model, is to have a very limited problem-solving focused therapy as part of what the care manager can deliver. Yeah. So it's not deep, it's certainly not deep psychoanalysis, but it's very focused therapy growing out of the cognitive behavioral approach, and that's really integrated into most of the care management programs that have developed following the impact model.
Yes, it was that way in the Diamond model in Minnesota too. And the care managers did this limited thing, and then in our setting where we had psychologists already on site, when the weeds got too deep for the care managers, they would consult with our therapists who would either do some of it or really back up the care coordinator.
All right.
May I
Excellent.
interject one question on that point?
Yes. Well, I think this will be, we have time for one more question, so go right ahead, please.
Sure. Just wondering, with the stepped care component from Dr. Unitzer's model, the evidence-based algorithm that they refer to in their materials, is there something that's standard? Is that derived from STAR-D? Is it an APA thing? Is it developed for each setting? To me, that would seem to add a lot of variability into these models, but if there's a gold standard for it, it would seem to be something we want to know about.
Well, in my understanding of this is that step care model evolved from their trials, their impact trials, and it is basically the idea is you start simple, and then if that isn't working, you quickly add something. You look at, gee, it's not working. The simple counseling or the simple behavior change, or if there's a medicine that's not helping, then what? What's the next level? How do you bring out the next level of care? Do you get the psychiatric consults? What do you just sort of move it up. And I can't remember the details now, but I remember in the Diamond Project, it showed steps. And they were really sort of logical. I mean, it was sort of intuitive that based on if what we're doing today isn't working, we have to get rid of something or accelerate something or put something new in there, and here's some possibilities to consider. And the rule was you had to just step it up if they weren't getting better, instead of having this sort of clinical inertia where you just kept doing the same thing for too long.
I see. That helps.
Good. All right. Well, Dr. Peak, thank you so much for this introduction to the council to this topic. And I know we'll be revisiting many of these issues, but I really think this has been a great start for them so that they can hit the ground running at the meeting. So,
well, I'm so pleased. I'm so pleased, and it's been a real honor to be part of this one and your California call too.
Thank you very, very much. Really appreciate it.
You're most welcome. Okay.
All right.
Bye-bye.
Bye. So the other folks, you should stay on the line because we have more ahead for you. This is a kind of an expanded call because a couple things. One is, first off, this topic is a difficult topic to do, and as you know, the report itself was quite long. That's because it included not just the evidence review, but also a lot of the work that we have found in the past when it's this kind of topic that really matters to decision makers. So that's kind of input from policy leaders around the country and especially around New England on what they see as some of the barriers and the facilitators to integration and that kind of thing. So I appreciate that there has been a lot for you to read, so thank you for that. The other thing we're doing is we are introducing a new way to vote on value. And so just briefly again, there are a couple of you who are new to CEPAC, but we have always viewed integrating considerations of value as a critical part of the CEPAC mission, so that we meet in public, we discuss evidence on value, and the council takes votes on value to help, again, everybody from patients to health insurers to provider groups and even society at large. We'd like to send the signal that it's not just possible but important to talk about value and to wrestle with it, even if it's not easy. So we have a new way to conceptualize and vote on value that we want to introduce now. And to do that, I want to turn back to the slides that are part of the webinar. So for those of you who have just been listening along, can you all look back at your computer screens? Does anybody not have access to the webinar? Good. Okay. So I'm going to, do I have control of the slides now, SJ?
Yep, you should, and let me know if it's not working, but you should be able to flip through.
All right. Well, if there's a way for it not to work, I will find it. Let me see.
We're here for you. We can fix it.
So I'm trying to figure out what, I'll just try page down and see what happens. No.
There you go.
Oh, I guess I can do it with my mouse. Okay. So follow along. The bouncing ball here is where we're going to go. So the ICER value framework, it's actually called a project here, and I'll say why. But first, why are we changing from the current approach? Again, those of you who've been with CEPAC for several years know that we have kind of revised the approach over the years as we've learned from you and from others about what seems to work and what doesn't work. And it's not that the current approach has been failing necessarily, but in certain cases we feel that it's been hard to disentangle some of the factors in the voting approach. And I'm not going to go into all the details of how we've been doing it, but again, you'll probably remember that we had you vote into one of 12 categories, like, you know, equivalent outcomes but higher cost. And we really left it to you to decide what higher cost meant, that kind of thing. So we feel like there have been certain topics like Sovaldi, which we did do out in California, which really made it difficult to use that simple an approach. And at the same time, we had been going through a multi-stakeholder project to develop a more kind of explicit value framework. And it wasn't just for us, it was really for payers as well. And we also recognize that CEPAC has a big topic coming up in which value will be very important. They're always important. It's always important, but the next topic after this one will be on some new drugs for cholesterol, around which there are a lot of very serious questions about value. So we thought it'd be a good time to go ahead and introduce this now. The long-range goals are to improve the reliability and the consistency of what we do through CEPAC, as well as, you know, other HTA groups and payers, and again, our larger mission to improve the transparency of the dialogue between all the different stakeholders around considerations of value. All right, so whoops, already messing this up. So just a quick peek at some of the participants, or actually this is probably all of the participants in the ICER policy development group. We consciously put together insurers, one patient organization, 2 employers, and you know, again, a set of manufacturers that included both drug manufacturers and device manufacturers to get their input on this as we went forward. But the goal was to create one that would be used by groups like CEPAC and payers, but would provide, in a sense, a language around value for all stakeholders. So what's the overall structure that we're going to be doing? It looks like a flow chart. And basically, I'll go through each of these buckets in a minute, but you start at the left, and you kind of go from left to right. And we're going to talk about comparative clinical effectiveness, incremental cost per outcomes achieved, potential additional benefits, contextual considerations regarding the illness and therapy. And if you think about those 4 things, you will be asked to then vote on what we are calling care value. After you vote on care value, a consideration around affordability will be your job to think about affordability, and again, I'll talk about what that means. And there will be a second vote, what we call health. Called in to put yourself on mute, please. Ooh, all right, whoever that was, hope they get back. All right, so that's the general structure, and obviously one of the bigger things is that there are now votes on 2 different types of value, not just one vote on value. And again, we'll explain the rationale behind that, and I bet you will understand. So let's go through each bucket, and I want to make sure we do this so we have plenty of time for Q&A. It's hard when I'm doing a webinar, but if someone feels like they have to jump in for a point of clarification, please do. But I'll certainly be done in time that we can circle back to ask questions. So the first bucket is comparative clinical effectiveness. Here's that same list again, just in a prettier picture, I guess. So comparative clinical effectiveness, relatively straightforward. I wish we could figure out who that is. We could maybe email them instructions on how to go on mute. Is everybody else hearing me okay?
Yeah, just fine until they call in.
Yeah, okay.
That was me. It's Chris Jones. I was just trying to launch it from my computer. Somehow it just went to the mic, but I've now found out a way to mute it. So
okay. Oh, it's okay. It's okay. Glad you're able to be back with us. So comparative clinical effectiveness is the magnitude of the comparative net health benefit, and it's kind of considered at the same time along with the level of certainty in the evidence on net health benefit. And this is not brand new to those of you who've been with us. This is the ICER evidence-based medicine matrix that we've been using for a while to talk about comparative clinical effectiveness. So we do talk about that, and it's one of the, it's obviously in many ways the driving consideration behind care value. The next bucket is incremental cost per outcomes achieved. Now, in many ways, this can be considered to be the average incremental costs for an individual patient to achieve the average net health benefits. For those who are fluent with cost effectiveness, this is basically incremental cost effectiveness. We decided not to use that word explicitly in the title just because that term cost effectiveness is misinterpreted by many people. It also has a lot of political baggage in the United States. But basically, there are two ways, to look at this. It's a relative measure, and you can either look at the incremental cost for a single desired clinical outcome. So, for instance, we could be comparing two different drugs that try to prevent strokes, and we could say this drug compared to current treatment, this new drug, it costs $100 to, on average, to prevent one more stroke, and the other drug costs $1,000 on average to prevent a stroke. And therefore, it would be easy to know which of the two drugs was the higher value, at least. Although that seems intuitive and in some ways preferable, most often we will want to go with a cost per an aggregated health measure because that allows you to compare apples to apples to apples across different kinds of interventions. And the international standard for many years, and in the U.S., has been the cost per quality adjusted life year. Now, again, we've done some training on QALYs, and I'm not going to get into the weeds on this, but we're very happy to do some more training, especially with new CEPAC members, and we can talk more about that. But what we're going to do with our own reports when we can, and this will be almost always, provide you a cost per QALY, is we're going to refer to thresholds that the World Health Organization has recommended. These are thresholds for deciding what the cost per, at what cost per QALY you get high value, that kind of thing. And the way the World Health Organization has done it is by linking it to the gross domestic product. This allows, obviously, countries that are wealthier, like the United States, to have a higher threshold, and developing countries, poorer countries, to have lower thresholds. So in the United States, following their guidelines, basically, we would have high care value as being any service that has an incremental cost per QALY of less than about $50,000 to $100,000 per QALY. Intermediate care value would be something that we're showing is between $50,000 to $150,000 per QALY. That's 1 to 3 times our gross domestic product per capita. And low care value would be anything that has a ratio above $100,000 to $150,000 per QALY. Now, again, we give you ranges. We're not necessarily saying that one specific number is a bright line and anything $1 above it is low value and $1 below it is high value. Everybody recognizes that there are lots of issues around the certainty of the information and other issues. So we're giving you these general ranges as at least a foothold, a benchmark to think about in your judgment of the incremental cost per outcomes achieved. Let me keep going, and then we'll pause at the end of care value, and we can see if there are any questions. So the next bucket is additional benefits. Now, additional benefits means any significant benefits, although honestly it could be disadvantages, that are offered by whatever the intervention is that we're looking at. Anyway, any significant benefits to caregivers, the delivery system, or other patients in the healthcare system that for whatever reason wouldn't have been captured in the available clinical evidence that would have been considered up to that point. So what do we mean by additional benefits? What kinds of things? Well, they could be mechanisms of treatment delivery that require many fewer visits to the clinician's office. Now, this is open for argument, always. Some people would say, well, if it's a little bit more convenient, I don't think that's really important enough. If it doesn't impact adherence and outcomes, then why would we really care? Others would want to hear arguments about whether convenience, for family members or for the patient would be particularly important for this, treatment. So this is where there's a lot of thinking and value judgments that you need to do yourself. It's not going to be spoon-fed to you. It's going to be a lot of thinking and discussion. But other types of additional benefits that might be considered are treatment outcomes that reduce disparities across various patient groups. It could be new mechanisms of action for treatments of clinical conditions like mental illness that have demonstrated low rates of response to currently available treatments. Basically what that means is that, for instance, in mental health, we often know that patients don't always respond to the first drug they try. And so what if there's a new drug that has a completely different mechanism of action to treat depression, and overall, on a population basis, its effectiveness really isn't that much better than current treatment, but because it works through a different mechanism of action, maybe it will help patients who don't receive benefits from the existing treatments. Now again, that's just a potential benefit. You might say, well, let's see the evidence that that is in fact the case. So these are just to provide a placeholder for you as a council to think about whether there might be additional benefits or disadvantages of whatever it is we're talking about that should be considered in voting on value. So, and that's just what that next one says. It's open for discussion, and there's no quantitative aspect to this. It's part of the balancing in the value judgments that you'll do. Similarly, contextual considerations capture a broad range of ethical, legal, or other issues, but not costs that could influence the relative priority of illnesses and their interventions. So, for instance, you might think it's particularly important that we're looking at a condition for which there's no acceptable treatment right now. This is the first one, and maybe that means a lot in terms of the context. Maybe we'll accept, a higher cost effectiveness ratio for it, that kind of thing. Is it a particularly very burdensome condition? Patients very severely affected? Does it involve patients who, for whatever reason, should be viewed as high-priority populations? And potentially, will the intervention be introduced through coverage with evidence development or other kind of policy mechanisms that can reduce, some of the uncertainties that we have about patient outcomes and costs? These are some. This is not the, again, this is a general category of contextual considerations that you may feel are important in your ultimate judgment of care value. So let me pause. Let me see what the next slide is actually. So let's look at this again before we go on to health system value. Imagine again thinking about comparative clinical effectiveness, the incremental cost per outcomes achieved. We'll be giving you all that information. We will also think about what potential additional benefits could be, and if there's evidence, we'll talk about it. But it's something you can discuss along with the contextual considerations for a vote on care value. I think I should probably pause at least briefly here before we go on to health system value to see if folks have any questions or comments.
Hi, it's Mitchell. I have a question/comment.
Yes. Go ahead / do it.
So what I wanted to bring up is cost sharing and the idea of what we're thinking about when we think of cost. And I'm getting at two different things. So the easy one is cost sharing. Are we talking about total cost or just the cost to the system? And that may come into play more with health system value. But the other one I think about is cost to the patient for ancillary services, like this is a debilitating treatment that will take a week in the hospital and they have time off from work. Or it's a regime where it's 10 separate office visits and they have to worry about either time off or child care. I think in the past for our economic models we've had to kind of bite our tongue and say, it's too complicated, we can't get into all of that. Where are we at this point?
Well, we've always said that we agreed that we needed to give you a perspective, as it's sometimes called. From whose perspective are we looking at costs and outcomes, too, to a certain extent, although we think of the outcomes as being the patient outcomes. In general, we use the Medicaid system as the perspective. So we look at the cost to Medicaid as a payer, and because there are very, very small out-of-pocket costs for Medicaid patients, that's meant in some ways to represent total health system costs. So we kind of, it's not really cheating, but we basically dodge the issue of out-of-pocket issues because we look at the Medicare cost structure. Now again, that obviously doesn't generalize always well at all to private healthcare insurance systems, and it's certainly something that we should feel free to talk about in terms of the nuance, but the general perspective will be the Medicaid system. Now when it comes up to things like productivity and times at work, we'll usually, well I shouldn't say usually, we always try to ask ahead of time to the stakeholders, being the provider groups, the payers, and others on our advisory board that do include patient advocates as well, and say, you know, is this a condition for which we really should work hard to include productivity as a key economic consideration, or not? It's always a good idea to think about doing that. When you try to do it, sometimes you end up with a lot of assumptions, more assumptions baked into your modeling that can leave people a little bit queasy because there's a lot of unknowns around productivity. You have to have assumptions around what kind of workers they are and how much they make per hour, and you know, how much do you assume that people who are working from home or at home as homemakers, how much should they be factored in? All of this can be done, but we generally try to ask and see if it's important enough to make it kind of the core analysis that we use.
Steve, this is Dan. Let me just jump in for a second.
Yeah, please do.
Mitchell, you were not part of CEPAC when we did our treatment-resistant depression review, but that particular model, because depression is so correlated with productivity loss and other indirect costs like it, we actually did, in our modeling, look at results with productivity costs included and excluded alternatively. So to Steve's point, when it's a topic where we think productivity or another indirect cost is quite important for that particular topic, and there is evidence on it that we can use to try to come up with a reasonable estimate, then we will do it.
Mitchell, did we come close to answering your question?
Yes, that's helpful.
Okay.
Hi,
it's a
Steve.
good question. Yeah, please go ahead.
This is Tony. A few minutes ago when I asked Dr. Peek about the small benefit that the evidence shows, he seemed to suggest that there were additional benefits that the evidence doesn't generally capture, and those probably are not so patient-based, not so clinically based, maybe more provider-based or process-based. So would that kind of evidence fall under additional benefits? And does additional benefits have to be evidence-based, or are they just information-based from, you know, public testimony or something else like that?
That is a perfect question. The answer is going to feel unsatisfactory.
Okay.
Well, the answer first is that that's exactly the kind of question that we want you to ask and to think about as you hear the evidence and you hear input from public commenters and others. Are there things that should be considered additional benefits or disadvantages that are somehow just not being factored in here? Now, if that's because they could be measured but haven't been, or if it's because they can't be measured for whatever reason that might be, we're going to leave it up to you to decide how important that is and whether it should be factored into your vote, you as an individual. And when we run the votes, I'll talk about this a little bit later, we're going to kind of look at this picture and, again, encourage you guys to verbalize your own thinking. Here's what I'm thinking about potential additional benefits and whether it might be important to my vote on care value, and maybe someone else will have a different perspective, and we can kind of flesh that out as part of what we're hoping is a little bit more transparent, explicit approach.
Okay, thanks.
And we will think ahead of time in terms of our own, the presentation from Dan and Jeff and where that might kind of occur. Good. Other comments or questions? We have health system value to come. All right.
Maybe just one quick one. Sorry to
Sure.
get at the last minute. This is Steve.
Yeah, Steve.
What we had just mentioned about assuming the perspective of the Medicaid system, In our work in Medicaid in Rhode Island, we find that a lot of individuals utilize community health centers, behavioral health, and it becomes more about integrating primary care into mental health services for many of those folks. And I'm looking at the pool of evidence that's been collected in this report, seeming to really be based more on commercially insured patients, or at least non-Medicaid populations. So I'm guessing that sort of puts me in the contextual considerations bucket in wondering about the application of the evidence.
Yeah, I think so. Again, because we use the Medicaid costs, and we do that partly because they are publicly available and therefore have some generalizability in a way. But you're right. If we're talking about kind of balancing the effects that we have seen from a program largely outside the Medicaid program, and all we're doing is kind of sticking Medicaid costs onto that, it introduces a generalizability question that is going to be at least something that you should consider without a doubt.
Okay, thank you.
All right, let me keep going, given we've got about 20 minutes left, and I want you to see the full enchilada, and then we can circle back. Okay, so imagine now, if you will, that you've thought about this care value, but now there's something else that we're going to ask you to talk about, and that's health system value. Basically, wherever you start from with care value, and I shouldn't almost say wherever you start with. If care value is low, then it's pretty hard for health system value to be anything but low. The reason that we have care value and health system value is because there are some interventions that might have kind of intermediate or high care value, but that end up basically not being affordable to the healthcare system because of the number of patients that you have to potentially treat. So, and you can imagine that hepatitis C is a classic example of this, in which whatever you might think of the care value at the individual patient level, if we have millions and millions of Americans who might get treated, you multiply, the costs times that number, and you get a very big issue around affordability. Now, we talk about affordability as something that should be managed. So your job, in a sense, is to talk about the affordability given the existing prices and payment mechanisms that we know about. But if you say that, care value is high, but affordability is a problem, and therefore health system value is low, what that's meant to be is a trigger, a signal that policymakers need to work on affordability. And that could be by lowering prices. It could be by changing how the payments are structured. It could be by prioritizing patients and timing them in different ways. So it's meant to send an important separate signal to distinguish between care value and health system value based on whether it's affordable in the short term. Let me just give you a little bit more background on this, then we'll circle back. Oh, but first, I'm sorry. We've talked about the thresholds around incremental cost per quality that are kind of baked into your thinking about care value. Well, we recognize that if we're going to have you vote on whether something is affordable or not, and you have, this has come up before, how much is too high a cost? So we actually took the effort to go out and talk to a lot of Medicaid programs, private health plans, pharmacy benefit managers, at least a dozen people that, and I've actually even done it now with an international set, and we asked them the following question. Well, it's tagged to the U.S. payer budget threshold, but here's the question. What is the single year total budget impact? By total, I mean on the entire healthcare spend, so not just drugs or not just whatever, on the entire healthcare budget. What's a single year total at which a single treatment, so it's a new treatment that's going to cost us more, at what total budget impact would that single treatment require some form of active management to avoid a high risk that care of equal or greater value would be displaced, and or that health insurance premiums would rise in a fashion that would adversely affect access to affordable care for all patients? Now, I know that sounds kind of like generic language, but we wanted to find out if there was any consistency around the way that payers would think about how much new cost they could swallow and not basically create real problems inside the healthcare system that could, in a sense, harm other patients. And somewhat remarkably, I think, but in some ways also fortunately, we got a very consistent answer, and the answer was 0.5 to 1% in 1 year, that they could swallow that much spending and kind of keep plowing ahead. Now, this depends a lot, even within that range. You've got Medicaid programs that tend to have less flexibility around their budgets, and in some years, even 0.5% for a single treatment might represent a big problem. Others, 1%, they could go higher than that. Maybe there is only one big new drug that year, and it's a national health plan, and they can absorb a little bit more of the cost. But this was the range that people talked about. So we decided to use it, again, since the vote is meant to send a signal that policymakers need to pay attention to affordability and figure it out. We decided to use that threshold in our own approach to providing you with evidence on affordability. So here's how we're proposing that you're going to use the overall framework. Again, it comes back to this value flow chart, but we're going to present the information, have you vote on care value. You will already have had, also the evidence given on affordability, and Dan will present that to you so that then you will follow on to a vote on health system value. And I'm going to give you just a couple of examples of how that could play out. And these are examples of how you might have different types of comparative clinical effectiveness leading to high care value and high health system value. So obviously, here are a couple of examples. Just if you judged that something was a superior comparative clinical effectiveness, the incremental cost per outcomes achieved, again, it either could be below whatever we've identified as the comparator, or more often we'll do below the threshold of 50 to 100,000 per QALY. You will consider whether there are additional benefits and the contextual considerations, but let's assume that that package gives you a care value vote of high. Then you will consider, is the baseline affordability, is the budget impact going to be below the threshold of 0.5 to 1%? PMPM stands for per member per month. That's just the way that insurers often think about the healthcare premium, the entire premium. And if it is, then you've got something that's high care value, and most likely your vote would be that it's high health system value too. The rest of this graph is just to show you that you don't have to have something that's superior compared to clinical effectiveness to get high value. You can have something that's just a little bit better clinically, but it still makes it, if you will, over the bar or under the bar of cost effectiveness. Again, maybe there are additional benefits, maybe there aren't, but let's say it's high care value. And again, if the budget impact is below that threshold, then logic would usually say that you should consider it high health system value. Even if something is only just as good as something else, if it's less expensive, here you don't even have to do a cost per QALY. If it's equally effective and less expensive, then you could say, well, that's high value. It's just as good but cheaper. And again, if using it, it's obviously going to be below the threshold because it's cheaper. So this is almost just a kind of a theoretical line right here. And the last one is sometimes even if the evidence isn't that strong and you think, well, it's promising but inconclusive, if the incremental cost effectiveness is quite good, maybe there's some additional benefits. Again, maybe you would end up thinking that that is high care value. If it is, then you would want to look again at the budget impact to decide what the health system value is. So we are going to, again, moving forward, we've already begun to use the terms of this framework in the draft report. You might not have noticed it yet, but it's in there. Certainly we've been using the terms from the ICER, evidence-based medicine matrix on comparative clinical effectiveness. So in the future, we're going to include in our reports our draft rating for the comparative clinical effectiveness. And it is a draft. It's our assessment of the comparative clinical effectiveness information. But we have decided not to include a draft rating for value because we really think that the value ratings will continue to require a lot of value judgments around things like additional benefits, how that factors in to the cost effectiveness threshold and how much certainty we have about it. There's still a lot of play in there that requires your judgment. So we're not going to give our own draft judgment on that. And you guys will vote on care value and health system value, and we'll give you even little paper copies of this framework so that you can kind of keep tabs on some of the issues you want to consider in your votes, things you want to talk about. And we've already test piloted this with the California group, and it actually worked quite well. We also, again, just asked them to write down their thoughts and other things, and we collected the pages afterwards, and it served as a really nice way for us to get insight into the thinking of the panel. So I think that is the last slide. Yes. So now I'm sure you probably have some more questions and thoughts, and be very welcome to answer them. Anybody want to ask a question about the budget impact piece? That's usually a piece that people are somewhat puzzled by.
Well, I was trying to let someone else go, but it's Mitchell
Go ahead.
again.
Go ahead.
I was wondering if you're thinking at all about population health when you're thinking about health system value. And I was trying to think about how this might be more appropriate given some of the current developments around ACOs and what they need to be thinking of. Does that make sense, or were you really thinking more tightly focused than that?
I think it was really the whole idea to have two different parts to value was driven largely by the recognition that when we voted on, when California voted on Sovaldi, the treatment for hepatitis C, they only had one vote for value, high, reasonable, or low. And when they all voted, or pretty much all voted low value, and we asked them why, they were saying, well, because it'll be so expensive, in the short term, no one can afford it. They really didn't talk about what's true, which is its long-term, relatively good cost effectiveness. I mean, if you look at the individual patient level, you get cost per qualities less than $30,000. It's not cost saving, but if we only had 100 patients to treat, it would be a good value, if you will, at the care value level. And it's only because you have to multiply the cost by such a large number of patients. So it does capture, I guess, the population perspective, but primarily it's not really different in terms of the health benefits at the population level versus individual. It's really more thinking about the aggregate cumulative costs in the short term and whether that's manageable. So that way, for instance, the second meeting on hepatitis C drugs out in California, they were able to vote that some drugs were high care value but low health system value, which we thought, again, did a better job of reflecting their true understanding of the information.
Okay, that makes sense. So that is a little different than I was thinking, because when I think about the triple aim in population health, part of that is taking a longer perspective, which I think people ended up having to do with Sovaldi, to go back to that case, to say you might avoid a transplant 10 years down the line, and if you take the broad perspective, then it becomes more appropriate.
Right. Now, I mean, the good news is that care value really captures a lot of what we want to think about, I think, from the population perspective about value. It's averaging, the average benefits way downstream and the cost way downstream. So we'll capture the cost offsets and all that. So even looking at that, most new things tend to add some cost to the healthcare system, and even if it's a good value, per se, quote unquote. And so we just recognize that we couldn't leave out affordability as part of this picture. So that's why there are two votes. And again, hopefully, a lot of the drugs, the real issue will be around care value. And the health system value, in a sense, won't be, it's just not going to be that big a deal because it won't be so many patients times such a high price that it will trigger the switch, if you will.
Makes sense. Thank you.
Okay. I know this is going to seem really kind of, and it'll be helpful, I think, when we're in the meeting and the slides have the graphic on it. And in moderating the meeting, it's also a little bit unfortunate that our first topic is behavioral health integration, because it's obviously not a classic drug test, procedure kind of topic. So some of these issues around value really, it makes sense, but it's a little bit more difficult to see it intuitively than if we were talking about a drug. Anybody else have a question or a comment or a concern? All right. It's hard to do this kind of introduction even through a webinar, and I recognize that when we can't see each other face-to-face. I know that some of you probably have a grumpy look on your face, and I would call on you to verbalize what you're feeling. But we'll get a chance to do that at the meeting. You guys have been, CEPAC has been absolutely instrumental, and as Mitchell and others who have been even on it longer will know, the feedback that you guys have given us over time has led to the evolution of our approach to voting on value. And we do think that this is an advance over the ways that we've done it before. If you remember some of the discomfort that you might have had on previous votes, we hope that this new framework will help address some of those discomforts. It may bring up new ones, but we hope overall that it's a good thing. So we appreciate your willingness to roll with this and to see how it goes, and we will learn from the process. But if you have any other questions about it between now and and Friday, please feel free to let us know, and we'll try to address it via email. But otherwise, we will definitely look forward to seeing you there on the day. SJ, I guess I hand it back over to you for any last words.
Sure. Thank you all again for your time. This session has been recorded, so I'll make sure you all can access that if you're interested in a refresher in the next couple of days before the meeting. We'll have materials for you on the day on Friday, so no worries about printing out anything I email between now and then, but please don't hesitate to get in touch with questions, and we're really looking forward to seeing you at the dinner on Thursday and for the meeting on Friday.
All right.
Thank you.
Great. Thank you, everybody. Really appreciate your time today. See you later this week.
Bye.
Bye.
Bye.